difficult. Come on, stand up, guys. Don't block the camera, but it's 2 on each side.
Do you guys have instruments? I don't have a hammer.
Who's got a hammer?
Oh, thank goodness. That will do.
We have 6 neurologists in the room and 1 hammer. Can somebody go grab one from somebody else?
Children took my hammer.
So to keep moving, when you're checking reflexes, generally for a comprehensive examination, we typically do ankles, patella, biceps, triceps, brachioradialis. Those are the standards. There are other reflexes that we can do, internal and external hamstrings. You can do deltoid, do jaw jerk. And certainly if you have a brisk person in the knees and the arms, you want to check the jaw to make sure they don't have a cervical myelopathy. Very good. So why don't you guys check my leg reflexes and tell me what I am? And I'll tell you if you're right or wrong.
Okay.
Or just, we'll do knees and ankles.
Sure. I like to put my finger there.
Good.
Good. Let's compare them side to side.
So if you're feeling for the contraction, again, you're not watching the limb move, you're feeling for the contraction, and you have to compare it based on how hard you hit. So you're hitting softer than Kyle, but my reflexes are not changing in between. So what would you guys grade me as?
Call that a 2.
2.
What do you think?
3.
So I'm a 2+.
Okay.
Well, I'm a 2 with too much coffee today. All right. So now, what about the way most of our patients in the hospital are? How are you going to check a patella reflex?
You can usually give them a little bit of slack, lift
Yeah.
the knee up a little bit, tell them to relax as much as you can.
Good.
We're actually creating a stretch there by lifting the knee up.
So the most important technical part of reflexes is making sure that the muscle involved is relaxed, but the tendon is taut. If you're not getting a reflex, it's because one of those 2 things is wrong. So if the patient's laying, you have to support the knee, and it does extend the patellar tendon a little bit so it's taut, as opposed to here where it's slacked. All right, what about ankles? And you can pick the naked foot or the other foot, whatever you want. So again, you want the muscle relaxed. My gastroc should be relaxed,
Yeah. Now
but is the tendon taut? My leg is moving all over. So good. Yeah, you can passively dorsiflex the foot a little bit.
got one.
Yep. The other thing you can do in a reclined patient is have them bring their leg up here.
And sometimes it's difficult to get to the actual Achilles tendon, so I'm sure you've seen people do this before. You can
Yeah, that's the way I do it too.
just like that.
But if you do that, you want to make sure that you're holding the ankle or the shin so you're bracing it. I prefer that way because then you're using the ankle as a fulcrum and the foot as a lever, and it gives you a better mechanical advantage. And don't be afraid to hit the reflex too hard. That's the other reason why you're not getting it, or why you wouldn't get it. So what was my ankle?
2.
Good. All right. So I don't have a neuropathy. All right. So with the arms, same deal. You want to make sure that the muscle is relaxed. You want the tendon taut, and you usually start off at about 45 degrees. With the seated patient, the patella and the ankles at 90 degrees. The arms are at 90 degrees. So just some hints. When you're doing a biceps, you want the arm over like this so you pop out that biceps, because with this, now your flexors are brachioradialis and biceps. But with brachioradialis, you want it in this position. Give it a try. So you got a great biceps reflex there. So you're hitting the insertion point. So you want to try to find where the belly of the muscle and the tendon meet, which is somewhere around here. No, try it up here.
Should hit up here.
And sometimes you got to search around for it a little bit. Sometimes I'll have the patient pop up the tendon by doing this. So here's the belly of the muscle. There's the tendon.
Okay.
And you want to make sure that this is relaxed.
Oh, sorry.
Don't apologize.
And then
So this is, the brachioradialis is the toughest one to get. And again, it's because usually the hand and the wrist is not relaxed. It should be there in that position. You're just going to have to tap around to find it. And sometimes, admittedly, I will tap around until I get where I'm looking for.
I think over here I feel the.
A little bit. Try a little bit farther back.
Okay.
So getting a little bit of finger flexion. So you want to get a little wrist jerk and a little finger flexion is what you're looking for.
Wrist. And then it's a little up. But isn't it extension over here like?
A little bit. You hit it harder. A little bit. Try the biceps. So again, the arm should be at about 90 degrees. The biceps muscle itself should be relaxed. So either the arm is resting or you're holding it up. You want to feel the tendon. This is the easiest one to get. So are you feeling it or are you seeing it?
Seeing it, I'm feeling it.
Good. So you want to grade it based on what you feel, not necessarily what you see. So you're hitting too soft too. You'll overcome that as the years go on.
Yeah.
If it's hard to find the tendon, ask them to flex
Yeah.
the biceps, and you can feel for the tendon and ask them to relax.
Can I hit the tendon directly, or is because we are taught not to hit it
You
directly?
can. I think it's a better way what you're doing. That's how I learned is you put your finger on it and then you hit your finger. I'll hold it up there.
Sorry.
Don't apologize. There you go. There you. Stronger.
You're hitting your own fingers, so don't be afraid to
Yeah.
really
Trust me, you're hurting more than I am.
give it a whack.
Try the triceps now.
I'm sorry.
Now triceps, again, you want the arm completely relaxed, and the hardest part is finding the tendon. And it's usually a little bit more medial than you anticipate. Sometimes you'll have the patient activate the muscle to feel it pop out. And this is another one where I personally will kind of tap around to localize it sometimes. You had it there. Sometimes you even back it up a little bit. There you go. Now remember, you're not going to see movement. You may only see the muscle pop out, or you'll feel the tendon pop out.
I'm not even feeling the contraction. So
I am. Now
maybe I can feel.
Navi, do you want to try? I had
So
triceps reflexes before, so I hope I didn't.
I'll do the biceps first, so relax your arm and
There you go. That's a good one.
so that is the biceps. I saw your triceps contracting.
Yep, that counts.
But sometimes I tend to do the triceps without my finger. Is that okay?
Whatever. I do it all with the fingers, but
Okay.
whatever you guys are used to. Some people even do the triceps like the scarecrow, but a lot of patients can't get their arm in this position, especially if they're old.
Brachioradialis. I felt it contract.
A little bit. Now, look at where you're hitting, though. You're giving me a supination, pronation reflex. What you want is this. So you want to find that tendon. Here's the muscle. Here's the tendon right in here. And again, the wrist should be completely relaxed. Hit down. There you go. You got a little biceps too, but it's there. See the fingers come in, the wrist goes up just a little bit. Brachioradialis is another one where you really want to hit hard. All right, reflexes, we're good?
Good.
Good?
I'm assuming that you guys know the grading of reflexes.
All right, so what, define a 4?
Clonus.
All right, so sustain, not clonus, but sustain clonus.
Yeah.
or something that is very, very wild. So you hit my knee real good. Okay, so that's a 2.5.
Okay.
Now I'm going to fake a 4. Watch out.
Oh.
Okay, the
Okay.
4, if you see it without clonus, the whole leg will come off the table, or there's a sustained extension of the leg. So what's a 3? More than a 2.
Yeah.
Okay, so reflexes are graded subjectively based on what you expect. Okay, a 2 and a 15-year-old girl on caffeine is not going to be the same as a 2 and an 80-year-old guy. But strength is always objective. It's always the same. So what's a 0?
You
Nothing.
don't see anything.
Yeah, nothing at all. Not even with facilitation. Facilitation with Gendrastic maneuver, reflection, like that. Okay, so sensation or sensory examination. When you're doing a screening sensory examination, you should at least do light touch. When you're doing a comprehensive examination for a consultation or an H&P, you need to do 1 small fiber and 1 large fiber. So for light touch, get a piece, can you grab a paper towel?
We have Q-tips and all that.
The most important message I can tell you for, either one, for light touch is don't use your fingers. You want to take something that has no weight and just graze the skin. Because if you displace the skin with your finger, even if you're touching lightly, that's not light touch anymore. Now that's pressure.
Okay.
So I use cotton, something like this. And again, you do all 4 extremities in the face. If they're normal at the ends of the extremity, you're done with sensation, or you're done with light touch, unless you're looking for a specific radiculopathy or mononeuropathy. In a comprehensive examination, you need to do 1 small fiber and 1 large fiber. Large fiber, you can do vibration or proprioception. Vibration tends to be more sensitive. And as we age, especially over the age of 65, you can even lose a little bit of vibration at the toes. So in the elderly, it's not necessarily pathologic if you've had reduced vibration in the toes. But if you're doing vibration, you go from bony prominence and you go up. You start here, on the top of the toe here. And if that's normal, you're done. If that's abnormal, you go to the next bony prominence. If that's abnormal, you go to the next bony prominence. And if that's abnormal, the next bony prominence. And if that's abnormal, you go to the next bony prominence. Same thing with the finger. Now, vibratory loss in the finger is always pathologic. Okay? In the elderly, you can lose a little bit in the toes, but in the fingers, no. Bony prominence, bony prominence, bony prominence, bony prominence, bony prominence. And you got to use a bigger tuning fork than
Yeah,
that.
this is one.
I have it.
It should carry a 128 hertz, 24 to
Yeah.
56.
That's fine. Yeah, it should be 128 hertz. Okay, good. So, to proprioception, somebody who wants to do proprioception on my finger, show me how you do it. This is probably the most technically difficult of the sensory examination, without blocking the camera.
Oh, all right. So, we're going to play a game. I'm going to either move your fingertip, so we brace the sides
Good.
like this, and then we move it either down like this, or up
Good.
like this.
Yeah, brace the next joint, and then you're going to move it like you did. The best is to hold it on the side. I've seen some people put it on the end, but you can still feel the pressure pushing up or down. It's best if you do the side. And you want to make very quick, small movements, 10 degrees in the fingers.
So is this up or down?
Well, you moved it twice. So you also need to tell them what you're doing. So have them watch you. Say, look, I'm moving it down, I'm
Yeah.
moving it up. So they know what up and down is, as opposed to I'm moving it down, I'm moving it up. No, you're moving it left and you're moving it right. So and make sure that they can feel it there. Now, quick movement down and keep it down. Try it again.
Up or down?
Down,
Okay. How about up or down?
up,
Very good. And up or down?
up. Good. You want to do it about 3-4 times. Okay?
He passes. We can try the other arm.
Yep, you want to do the other arm. So who wants to do my toe?
All right. So I'm gonna hold your toe. I'm gonna move it up this way or down this
Good.
way.
I see what you're doing. I know what down and up is. Good.
All right, I want you to close your eyes and tell me which direction I'm moving.
Down. 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 Up. Good. And you want to be a little sneaky about the pattern. Don't do up, down for every toe. And the toe, you give them a little bit more leeway. Toe is 20 degrees, but again, it should be a very quick, sudden movement. So what if I have no proprioception in my toe? Then what do you do? Ankle. How do you do that? Show me. So you want to go to the ankle instead of the proximal toe, because if you're checking proprioception at the proximal toe, they're going to be able to feel the skin move because it's not a pure joint.
So I'm going to move your ankle up and down. So up and then down.
So you want to brace the malleoli. So you're going to hold the medial and the lateral malleolus, and then you're going to want to hold the side like you're doing.
Okay.
With depending on the size of your hands, without trying to push up or down on the top of the foot.
Okay.
But ideally, like that.
Okay.
And
Close your eyes.
up. Wait, okay, you didn't ask.
Up or down?
Up,
Up or down?
up,
Up or down?
down. Good, so I'm okay. So that's large fiber, okay? Vibration and proprioception. Small fiber is pain and temperature. We tend not to do pain as much because obviously there's some risk involved, bleeding, pain. So temperature tends to be a good one. And the flat side of your tuning fork is an easy tool to use. However, if it's been in your pocket all day, it's not going to be cold. So you can run it underwater or put it over the air return in the room. And when you're doing temperature, again, you're going to do all 4 extremities at the ends and the face. And if they're fine distally, you're probably okay from there. You want to find for temperature a soft surface, not a hard surface. And you kind of want to stay away from the meaty part of the palms too. So you want to get this nice soft skin here, on the back of the finger here, and on the foot, the top of the toe, the arch, so that you're really getting temperature sensation. And remember that temperature is unmyelinated C fibers, so it's not always right away. If you say your tuning fork is cold, let me see. So check my temperature on my left foot. No. Okay. But, so it's not very cold, but the other point I'm trying to make is it may take a second or two. They may say, no, I can't feel it. Oh, okay, wait, yep, now I'm getting it. So you got to give them a minute or two. Try not to do warm or hot. You can do it in certain situations, but you prefer to do cold because you can actually burn somebody if they can't feel it. Now, pain. Pain's an important test to do for myelopathies and certain types of mononeuropathies, but it's also difficult to do. Do you guys carry pins with you?
Q-tip.
So somebody break a Q-tip and show me how you're going to do it. Yeah, so it's sharp. So, but you're also going to make sure that you have controls. You want to know not if they can feel the pain, but if they can differentiate it from not sharp. So if you just tap them with that and say, can you feel this? Well, yeah, you can feel that because it's pressure and pain or whatever. You want to be able to see, can they tell the difference between the sharp end and the dull end without putting too much pressure on there. So give it a try. I have no communicable bloodborne diseases.
Do you feel this as a prick or a pressure?
I feel a sharp tap.
Okay. Is it the same on this side as well?
Yeah. But I don't know if that's any different than the soft end.
Oh.
So maybe if you touch me with the Q-tip end, I may still feel sharp because I've got a dysesthetic neuropathy.
Oh, okay. So how does this feel, like a prick or a pressure?
That's just a tap.
Okay.
So good, you've demonstrated that they can tell the sharpness from the pressure. The other thing the other way you can do it is by a scratch. So if you take that sharp end and you lightly scratch the skin and that feels like a scratch versus the Q-tip end and it feels smooth, that is similar. So yeah, with pain, make sure they can differentiate sharp from not sharp. Any questions about sensation? Sensory examination should be binary. Either they can feel sharp, they can feel temperature, they can feel vibration, or they can't. You can note, they said, well, that's about half as strong or 70% as strong, but that's pretty subjective. Really what you're looking for, can they feel it, can they not feel it? Is it cold or is it not cold? You'll get on a wild goose chase with localization if you're trying to chase down 30% coldness versus 50% coldness. All right, strength. So, what muscles do you check on a full comprehensive examination? Yep, neck flexion, extension,
delts,
deltoids,
biceps, triceps, wrist extension, sometimes wrist flexion, finger extension, finger flexion, interossei, and the APB as well.
yeah. If you're doing neuromuscular, you're going to want to do the hands with greater detail. So in a screening examination, the gross muscles, but on hands, Kyle, show me how you check my interossei. Do a hand strength examination here.
Sure. All right, in just your hands. So we'll start with the, I guess that is all forearms. So interossei, I usually just do the FDI. So spread your fingers apart like I am. And then we test with the same finger, in the same action, in the same plane, as close as you can. Push against me, don't let me push your finger in. Good?
Okay. So that's good. What you did with the same motion and the same muscle, that's a decent technique. However, it breaks down when you're checking other things that obviously you can't check somebody's deltoid with your deltoid. So a better way to do it is to brace the proximal joint. So if you're checking abduction here, it's abduction across this joint. So you brace it at that joint. You make that joint the fulcrum, and the finger is the lever. So with the abduction, with the interossei, you can do these three fingers together, and they actually brace themselves. This is all the same innervation for the most part. You can do FDI, the first dorsal interosseous, and have them make a gun and do that. But this way tends to be better. Now this one is a different nerve and a different muscle altogether. This is the adductor digiti minimi quinti, ulnar. So for this one, you want to brace the joint, push. But brace it here, because if you brace it here, now you're not getting my ADMQ, you're getting all of my ulnar deviation of that wrist. All right, so you guys know how to do median, radial, and ulnar with the thumb?
So,
I know median and ulnar. I don't know. I've never. I think you can do radial, but I have never done it.
Yeah, extension. So the radial is thumb extension, and thumb extension is not this, it's this. That's a subtle difference, okay? So I'm trying to pull it out as opposed to that. What's this?
adduction.
Adduction. So what's this?
That is
Abduction.
extension.
That's a trick. This is abduction. So abduction, the abductor pollicis brevis, is moves the thumb perpendicular to the plane of the hand. So you brace the hand, push down, there's your median nerve, okay? Now, radial is this. Here's the radial tendon, you're going against the tendon back here. Not this, this. You're gonna brace it, push down. Adduction, into the hand, and you try to pry it apart from the hand itself. Okay, in the legs, what do you test? Or better yet, show me in a reclined patient who's laying in bed, which makes it even more difficult.
You got your hip flexion.
All right, test my hip flexion. How do you do that?
All right, please raise your right leg up as high as you can. Don't let me push down.
All right, so no, you want to, first of all, brace the hip. Easy there, buddy. And you want to make sure you're just checking hip flexion, so you're going to push down on the knee.
Advanced Neurological Exam, this is your 5-minute warning.
Good.
5-minute warning.
Now,
Thank you.
quadriceps.
All right, I want you to, I'm going to support here at the knee.
Good. You're bracing the knee. You're bracing the fulcrum.
Lift your heel up off the table. Do not let me push your foot down.
I've already locked my knee, though, so you want to test it when it's between 45 and 90 degrees, because if I'm already here and lock my knee, you're not going to be able to break it.
Yeah, impossible.
So you want to get it right about there.
Okay.
Push. Perfect. Okay, hamstrings.
All right, I want you to bend your knee and don't let me straighten it out.
All right. Yeah, good. Okay, so brace the knee and pull out like that. Try to make sure that the heel is not in contact with the bed, because then you got friction here and not just strength. You know, you're trying to pull it, but you're pulling against not just my hamstrings, but the friction of my heel or shoe against the bed. All right, dorsiflexion and plantar flexion are pretty straightforward. understand that dorsiflexion, you should be able to fight it or come even to break it, but you should never, ever, ever be able to break anybody's plantar flexion, even the 90-year-old lady. That's always going to be too strong.
Inversion, eversion in some cases.
Yeah, somebody check my eversion and inversion.
This foot, can you lift the outer edge up?
The outer edge up.
So I just put my hand there and say push it again.
Yeah, that's a
Push
good way
against
to.
my hand.
It's difficult to explain that to patients. So,
I'll push against my hand here towards inwards.
yeah, or sometimes I'll show them with my hands and I'll say, do this and do that with your feet. Everybody kind of knows what that is. All right, so strength grading. What's a 3?
3 is the one where the person can lift against the gravity, but they can hold it against the gravity, like against resistance.
So a 3 by definition is they can hold it and sustain it against gravity. But as soon as there's any resistance, it goes down. That's a 3. So then what's a 4?
They can hold it against the gravity and they can also hold it against the resistance.
Yeah, a little resistance, but not enough. And the 5 is 5.
So what's the difference between 4 and 5?
4, you can overcome their strength with resistance. They're able to provide some resistance to your strength, but not completely. With 5, you're absolutely not able to break their movement.
And you got to think about who the patient is sometimes.
Yeah, well, strength testing is objective. There's a little bit of subjectivity between a 4 and a 5 based on what you think they can do. What's a 2?
They can just move their limbs against the gravity. In the absence of gravity, they can move their limbs, but they cannot move their limbs against the gravity.
Okay, so show me how you would test that in my wrist. You've already determined that I don't have anti-gravity, so now you're seeing if I have a 2. How would you check my wrist strength by eliminating gravity?
I'll ask you to keep it here and maybe try to move it side for that.
Hold the joint, again, brace the fulcrum, and now we're going to move it in this horizontal plane so there's no gravity involved. And a 2 would be I can move it one way or the other, but when I do this, I can't move it. So then what's a 1?
I think the 1 is
Flicker of contraction.
Any contraction, but you can't technically move it against gravity. So in this setting, if this is a 2, a 1 would be some palpable or visual movement. And again, there's some muscles you'll be able to overcome in everybody with mechanical advantage, like the fingers, and some you'll never be able to overcome, like plantar flexion, biceps, quadriceps. You just get used to knowing what's normal. Good. Any questions about that?
So don't forget about abduction and adduction.
True. Yeah. Doing hip movements in the seated position is not ideal. We'll do it in screening examinations, but if you're really concerned about proximal leg strength, you need to have them lay down and do what Kyle did by bracing the hip and pushing up here, or pushing out with these, or pushing in. Or how would you check hip extension?
I usually place a hand below their hamstrings and ask them to push my hand down onto the bed.
While you try to lift up?
Yep.
Yeah. Yeah, good.
And I'm not able to break.
And you should never be able to break that. That's another one.
So how do you say you're not able to break him, but how do you say it's 3 by 5?
No, it's 5 by 5 in his.
No, yeah, he doesn't
In
have 5
3,
by 5.
you have to actually place them in a prone position
True.
and ask them to lift it up
Lateral.
to eliminate gravity.
Which is a difficult thing to do for most patients. But in a dedicated, thorough neuromuscular examination, sometimes you need to do those things.
In case like the pseudo weakness patients where they have a lot of quarter foot weakness, will the testing the adductors and abductors help in classifying the weakness, whether it's genuine or not?
If doing bilateral testing at the same time can help discriminate that. And the beauty of abduction and adduction is because you're using each limb to brace itself. So it's very hard to fake or have unilateral weakness unless it's real.